This is a case of a 34-year-old male who allegedly suffered a penetrating injury while working in the field with a stick. So he presented to us the next day, and this was the picture. You can see there is a corneal tear, although it was sealed at the time. Very loosely sealed, as you can see from what I am showing with the dialer. I'm just separating it out so that I can suture it with better opposition. And there was, of course, an open capsule and a traumatic cataract. The upper part of the anterior chamber was completely shallow. So initially here you can see I am going to go ahead and suture the wound. Although it is partially sealed, it's no use. Once I start handling the cataract, it is going to open up. So better to put the sutures before attempting the cataract. So here I have put in 3 sutures across this curvilinear tear, and initially I am putting in 2 side port incisions, not at very strategic positions, but you should remember that the upper part of the AC is completely flat, so I can't exactly put my side port incision there. So once I've done that, I put in some air. The idea is to stain the capsule and better delineate the tear. So I expel both the air and the trypan blue with HPMC, and now you can see the lower part of the tear very clearly demarcated. So I just gone in with my dialer through one of the side ports, and this is basically to there is slight opposition of this iris against the cornea. I just push it down because this is the area that I am going to enter with my keratoconus. Rather than making a clear corneal incision, I decided to make a sclerocorneal tunnel so as to give me more space within the cornea. So just fashioning my tunnel, and then I enter with my 2.8 millimeter keratoconus. Just decompressing a bit. I then hydrate the cortex with some BSS, just loosen it up. The next part of the strategy would be to aspirate this cortex, this loose cortex, using a Simcoe for this. Very gently. I don't want to extend this tear to the posterior capsule. This is still, although it's been taken up about 3 days after the injury, it's still a very early fresh wound. So just aspirating as much as possible with the Simcoe. There is no nucleus, so I just have to aspirate the cortex. But that is also not that easy because the view is not exactly that clear. Very difficult to view through this corneal tear, and moreover this tear is getting hydrated as well. Just trying to take out as much as of the cortex as possible safely. I take advantage of the side port as well and remove whatever cortex is accessible in that area. Finally, I decided to put in some adrenaline as well. And that was probably a good decision because the pupil dilated pretty well. Then instead of using the Simcoe, I go ahead with the bimanual, hoping that this would be a better option to remove the cortex. I have to be extremely careful not to engage the capsule. And you can see here I have engaged the superior capsule and I have to let it go and then go below it and then remove the cortex. So these small things that matter, because if you get impatient in these cases, it's very easy to open up into the posterior capsule and bring out vitreous, after which you have basically lost the battle. So you have to be very, very careful in these cases. Yes, the view is not so great, but by feel you can remove most of the cortex. And that's it, it's done. And you can see the lower part, the tone edges of the capsule, both inferiorly and superiorly. Then put in some HPMC, and I have decided to go ahead and put in a 3-piece or a multi-piece IOL within the bag. These lenses are a bit difficult to handle. You have to watch very, very, very carefully. But if you take adequate care, I think this is the best lens to implant. I put in another side port so as to do this particular maneuver to manipulate the 3-piece lens into the bag. I have to tuck in the superior haptic or the trailing haptic into the bag. I use some HPMC to assist me. I then go in with my Sinskey hook and tuck in the trailing haptic into that, under that superior part of the capsule. And now I take a micro scissors, make a small nick in the inferior tear, and scallop that capsule. This is a very crude rexus, but it works. And that's it. Once I have done that, I then bury all the knots. Remove all the HPMC, fill in the chamber with in fact pressurize it with BSS. And now this is a very important step, because you really have to check that corneal wound to see whether it's leaking. Putting in some trypan blue, I then hydrate through a side port, and you can see the leak there. There is definitely a leak. I wash off the trypan blue and then go ahead and suture that area as well. Decide to put 2 more short sutures. This will not only close the leak, but it will also bring about better apposition of the wound edges. Then bury those knots. Again check with trypan blue and pressurize the chamber. Now it's not leaking. I then go ahead, put in my intracameral antibiotic and conclude my surgery. Thank you so much for watching.